Welcome to the 13th Annual Sentinel Public Training. My name is Jennifer Lyons. I'm an epidemiologist with the Sentinel Operations Center at Harvard Pilgrim Healthcare Institute. And I'm very happy to be facilitating this morning's training and also to be giving one of the presentations. I'd like to first hand things over to FDA's Dr. Gerald Delpan, who will be providing some opening remarks. Dr. Delpan is the director of the Office of Surveillance and Epidemiology and the Center for Drug Evaluation and Research at FDA. Thank you, Dr. Delpan.
So thank you, Dr. Lyons. I'd like to welcome everybody to the Sentinel's 2022 Virtual Training Day. And what we've found over the years that these training days really offer something to everyone, to a wide audience, whether you're brushing up on your skills or whether you're a new analyst and are just learning about Sentinel, industry representatives, public health representatives who have an interest in leveraging real-world data to transform it into real-world evidence. I think everybody can find something here. And I think based on the registration, I think we have a very diverse group here today. Our presenters here will start by orienting us to the Sentinel system, and then we'll ease us into some fairly complex topics, such as inverse probability weighting and inverse probability of treatment weighting, and a discussion how these types of approaches can reduce confounding bias in observational studies of medical treatments. These kinds of enhancements to Sentinel expand the kind of analytic flexibility we have, the kind of flexibility we've tried to build into the system over the years. And in doing so, it strengthens our capacity to use real-world data and therefore real-world evidence, and thus further contributing the kind of data streams that we at FDA have to do our job of monitoring the safety of medicine. So before I hand it back to Dr. Lyons, I'd like to thank each of you for joining us today. Your presence here shows us that you're interested in investing your time in learning about our system. I'd also like to thank the many people who worked to make today's presentation possible. For sure, the presenters, but all the people behind them as well, who do so much operational work to make this happen. I'm sure we'll all appreciate their efforts. So let's get into the presentations, and Dr. Lyons, I'll turn it over to you. Thank you.
Thank you, Dr. Delpan, and welcome everyone again. I'm Jennifer Lyons, an epidemiologist in the Sentinel Operations Center at Harvard Pilgrim Healthcare Institute. And before we jump into the training, I'm going to walk you through the agenda. So we have three main presentations today. I'll be starting with a big picture overview of what the Sentinel system is and a broad overview of our analytic capabilities, really a crash course. And the remainder of the morning will be focused on our inverse probability weighting. Dr. Xiaojuan Li, who is an instructor in the Department of Population Medicine at Harvard Medical School and Harvard Pilgrim Healthcare Institute, will be giving an overview of inverse probability weighting. And then Dr. John Connolly, an epidemiologist at the Sentinel Operations Center and Harvard Pilgrim Healthcare Institute, will be demonstrating how we use inverse probability weighting at Sentinel with a specific use case. Let me give you a little more detail about the structure of the morning. So before I officially get started, we'll be doing a brief pre-training survey to get a rough sense of where people are before the training. And then I'll give my presentation about the big picture overview, and then Dr. Lee will give her talk. After that, we'll do take a 20-minute break before Dr. Connolly presents the use case. And at the end, we'll do another post-training survey. We love our data. And a couple of other notes here. You'll see there's a Q&A box at the bottom of your screen, and we have that there for you to share any questions you have so everyone can see those questions. Throughout our presentations, we'll have a Sentinel team monitoring that Q&A and addressing those questions as they've come up. We've also built in 5 minutes after each talk to answer any questions that remain. If you would prefer to ask your question live instead of typing it in the QA, you'll just have to ask one of the moderators to unmute you first via chat. And all of these slides will be posted publicly, and everyone who has registered will get a link to the slides. And as you probably heard, today's training is also being recorded. So at this time, I'd like to open up the pre-training survey. And if everyone could answer these questions, it would be helpful to us. Once the survey is complete, I'll come back and we'll get started with the training itself. All right, thanks everyone who filled out the survey so we could get a sense of who our attendees are and where you are in regards to understanding Sentinel. I see we have a lot of representatives from government and pharma, a lot of epidemiologists and others. So thank you so much. And with that, let us get into the training. So the first portion of today's training will be a rather high-level overview introducing the Sentinel system. So what is Sentinel? The Sentinel system is an active surveillance system that fits within the Sentinel initiative of FDA, and it's focused on giving FDA the ability to assess medical product utilization, safety, and effectiveness. So the Sentinel system is just one of the many tools that FDA has to do its job, and it's rooted in the use of real-world data. And that real-world data is primarily comprised of data collected as part of health insurance, administrative claims, electronic health records, and patient reports in the United States. To analyze this data, we use computer programs, which we call our analytic tools, that allow us to ask standard regulatory questions about medical product use and safety. And from describing how patients are prescribed their medications to figuring out if certain medicines have side effects that interfere with patients' lives, all of these can be answered with Sentinel's analytic tools. Now, in terms of privacy and confidentiality, Sentinel is different from other types of databases in that there's no identifiable information that leaves the data partners themselves. It's a core aspect of what Sentinel is and how we function. So we never see identifiable information about patients. All of these components come together to help the FDA answer regulatory questions on behalf of the public. And after the FDA conducts one of these analyses in Sentinel, the findings can be used to help determine whether medical products of interest are safe and effective. It can also inform advisory committee meetings, be used to develop drug safety communications, inform label changes, and much more. So foundationally, the Sentinel system is a distributed data network. In a distributed data network, there's no centrally located data source. Instead, the data are collected and then maintained and analyzed at each individual data holder, which we refer to as data partners. And our data partners participate in the larger distributed data network by transforming their data into the Sentinel Common Data Model so that all the data from the different data partners is structured the same way. So you'll see on the left here, the structure is the Common Data Model, which I'll get into in a few slides. And since all the data partners have their data formatted the same way, this allows us at Sentinel to work with FDA to design an analysis and then share that as a computer program or analytic tool for each data partner to run against these data. So the Sentinel Operations Center will write these computer programs, distribute them to the data partners who will then run the analyses on their data in-house before returning aggregated results to us in a structured way and secured way. In general, these are aggregated in that we have no individual level data from each data partner, and then we further aggregate across the data partners and return these results to the FDA. We do have a lot of collaborators at Sentinel, as you can see. So the Sentinel Operations Center resides within the Harvard Pilgrim Healthcare Institute. And our scientific partners are those institutions that work with us and FDA to design studies and conduct analyses within the Sentinel system. And our data partners consist of those organizations that include their data in the Sentinel distributed data network, such that we can run analyses using their data. There is an enormous range in who the Sentinel data partners are and the amount and type of data that are available at each institution. At this time, the Sentinel system is primarily comprised of administrative claims data from our large national health plans, and representing these, you'll see Health Corps, which has Anthem insurance data, Humana and Optum. We also have integrated delivery systems, those organizations that provide care, as well as insurance, such as the Kaiser Permanente sites. And importantly, CMS also participates via colleagues at Duke with the Medicare fee-for-service data. So the Sentinel data partners include everything really from large national insurers to the smaller regional integrated delivery systems. And because we have so many collaborators and such a wide range of patients represented from different types of organizations, the size and representativeness of the system really allows FDA to assess so many different products and outcomes, including those that are not used routinely or even rare events, which is some of Sentinel's biggest strengths. So, underscoring the work that we do is our data philosophy at Sentinel. Now, our data predominantly consists of health insurance claims with some EHR data and the capability to bring in registry data. But really, it's not that static, as the data model is developed with enough flexibility to be expanded as needed. And it's changing all the time. And this means that the data elements are included in specific tables with a specific structure. And it's set up so that we can add in new data domains and data elements as the availability and our capability evolves. The data partners also populate the tables that make sense given the data they have. So it's not one size fits all, but rather quite adaptable based on the available data. And the way we've defined the data model is the most granular level possible with minimal mapping. And what that means is that we have the minimum specific information stored in each cell of the data set. So for example, we have diagnosis codes and procedure codes, but not necessarily a concept of a disease or a treatment. But you can use these diagnosis and procedure codes to construct an algorithm to identify an outcome. So this means if you wanted to study a particular condition, you could develop an outcome algorithm based on the presence of the diagnosis procedure codes or dispensings and use the definition in your analysis. We don't have that outcome algorithm stored in our data, but we have the pieces that were used to create the algorithm. And we can also store the logic used to create those outcome definitions for use by future investigators. And this is another strength of the Sentinel system. There's just enormous flexibility in what we're able to study because we don't impose our own definitions on the data, but we do make these algorithms available as needed. And another important concept of our data philosophy is that the data partners themselves are part of the system, not just as data sources, but as partners. And they bring their knowledge and expertise of their own data. The data partners not only help us understand what their data look like and how to use it, but also how to interpret results. They also populate tables that are appropriate for the data they have. Again, so it's not one size fits all. And most importantly, the whole system has been designed to enable flexibility and transparency. And that means that the control is within the data partners. They keep their own data in-house behind their own firewalls. They run analyses themselves. They review the results before sharing securely with the Operations Center and before we're able to aggregate and share with FDA. And what does the Sentinel Common Data Model look like? There are a lot of available data elements here. I'm going to review these quite briefly. First, we have a group of data elements that are considered as administrative data. And these include things like enrollment, which outlines specific start and end dates for someone's insurance coverage. We also have information about their demographic characteristics, as well as diagnosis codes and procedure codes that refer to diagnoses and treatments. And then we have prescription data, which are captured as dispensings and at a subset of data partners as prescription data. There's also two tables that get at clinical data, so our lab results and vital signs, and those generally come from EHR data, not always, but particularly their lab results can come from claims data as well. And on the bottom left, we have a couple tables here under the heading of registry data, where we have the capacity to bring in data from a few different types of registries. So in the past, we've been able to look at vaccine registry data, looking at vaccine safety, and we also have the ability to ascertain death and cause of death from state registries. And there's a couple of tables specific to the inpatient setting, including inpatient pharmacy data in terms of administration of drugs, as well as inpatient transfusion data. We have the mother-infant linkage table, which is the linkage between a patient with a record of a live birth delivery and the infant. So that information about both can be included in the same analysis. And then our most recent update to the Common Data Model is the inclusion of auxiliary data, which includes information about facility and provider. So I'm going to just walk through an example of what this might look for a specific patient with data in the Common Data Model. So you see here the demographic information. So this is a female born in 1984 who had an inpatient encounter. You see the ENC type column is IP, so that denotes it as an inpatient encounter. So this woman was admitted on October 18th, 2005. And during that hospitalization, as you can see, this patient had a number of different diagnoses with the specific diagnosis codes recorded in the DX column. And you can see that there's a procedure as well recorded during that inpatient encounter. And finally, you can see that this patient had a pregnancy, that resulted in a live birth delivery, and she was linked to her infant. So, this is just an example patient we've created for illustrative purposes, but it gives you an example of how the data are captured in the different tables, how they are organized, and then how they might be available for use by our different analytic tools. So when data partners transform their data into the common data model, it first must go through a data quality review and characterization process. And this is a robust quality assurance and review period where every single time a data partner updates their data, we work with them to ensure that their data look and are performing as expected. So starting here at step 1, the preparation phase, we at the Sentinel Operations Center will develop our QA package. Essentially, this is a set of computer programs that the data partners run every time they update their Sentinel data. Updates occur at a range of frequencies, some annually, some quarterly, and every time the data partners update, they run a set of packages to check the data. And we work with them through the process to ensure the new data are meeting our expectations. As we move through this process to step 4, there are more than 900 different checks that are run. And these checks can create a number of flags as needed to prompt the data partners to investigate this issue and to work with us to ensure that anything that needs to be resolved does get resolved. And this is an iterative process as we at SOC work with our data partners to understand the reason for the data being flagged, to really understand what's going on with their data. So it might look problematic at first glance, but ultimately the data partners as owners of their data, who know their data best, work through the process to make sure everything is as expected. In the end, after all the flags are addressed, the newly refreshed data is approved and becomes the data set that will be available when the FDA turns to Sentinel to answer a question. And there are 3 main levels of checks we conduct as part of this quality assurance package. Level 1 is the most basic, where we look within single tables. And this is looking to see, are the data elements complete? Are they in the formats we expect? Basically, is the common data model format being followed? And then the checks get increasingly complex. So at level 2, we have logic checks to assess cross-table accuracy and integrity. And this means that when we take information that's captured in multiple tables, that the information makes sense together. So for example, does the admission date come before a discharge date for a hospitalization, or do we only see admission dates during times when someone is actively enrolled in insurance? And lastly, and this is an important point, is the cross-time checks at level 3. Now, every time data partners update their data, we are essentially overwriting that data that is in Sentinel. Much of the prior data is saved in case we need to go back to it, but the data that's within the system, that's an overall rewrite. We want to make sure that there's no major change from one refresh to the next. And for example, if we're expecting to see a certain number of admissions generally per month or per year within this data partner's data, are we seeing that? Is there anything that looks odd about trends from one refresh to the next? And sometimes there's a good explanation. Perhaps that organization has acquired another health plan or seen a substantial increase in their membership. We work with the data partner to make sure that we understand whether there's either an anomaly or error in the data, or if there's an explanation for it. Currently, we have a total of 360.2 million unique patient identifiers and about 64.3 million members actively accruing data. We distinguish patient identifiers from members in the Sentinel distributed database, and this is important. So every member has a patient identifier, and that comes from their health insurance. They have an enrollment start attached to that identifier. And at some point, if the member disenrolls or changes the health plan for any reason, that patient identifier will have an enrollment end date. So if that same patient enrolls in a new health plan that's included in Sentinel, they will receive a new patient identifier. And then we would have 2 patient identifiers in this Sentinel distributed database. And that just means at this time, we do not link across health insurance plans. So members would be in the database with 2 separate times with 2 separate enrollment start and end dates and 2 separate patient identifiers. This figure here gives a sense of the current size of the system and how it has grown over time. So early on in the mini Sentinel phase, which was the pilot phase of Sentinel, we reached the goal of 100 million unique patient identifiers, and that was in 2011. Another big milestone to note is on the end, at the point where Medicare fee-for-service data were brought in January 2018, and you can see that large increase. So with the large numbers comes a greater ability of the FDA to investigate medical product safety, and particular ability to evaluate those products with low use, as well as rare disease outcomes. Okay, so that was really our crash course of Sentinel, what the network is, how the distributed network works, what our common data model is, QA and size of the system. What I'm going to spend a good portion of the rest of my time on is talking about our routine analytic tools and walking through some different examples using our tools. So this is one way we can conceptualize our tool capabilities, the active risk identification and analysis, or ARIA. It's a component of the Sentinel system that's used to conduct medical product safety surveillance. We have 3 levels of tools in addition to the capability for signal identification, which we use to detect new and unsuspected potential safety concerns. The first level is descriptive analyses that are unadjusted, and that includes analyses run through the Sentinel Query Builder, which is a web-based application to run certain types of Sentinel analyses with a user-friendly interface. At level 2 is a set of inferential analyses that have confounding control. And then level 3 is when we're doing sequential analyses that are adjusted for confounding. And these tools, as I mentioned, are computer programs. They've been designed to answer a specific set of questions that FDA asks on a regular basis. They have a lot of flexibility, so they can be parameterized based on what the question is that FDA has at the time, or what question you have if you're using the tools too. They're able to be used very quickly and efficiently once they're developed. You can think of them as just off-the-shelf tools. They've been tested and quality checked before they're made public to you, for those of you who are external to FDA, and also before they're being used within the system. The other bonus of these tools is they generate standard output, which consists of tables and sometimes figures, depending on the tool you're using. So you can see at the top of the screen, we have our circles for the signal identification in different levels. And so we go from that to our much more detailed tools list, which are structured based on this question: what are you investigating? And all of our tools are categorized based on this question and 3 broad types of investigations that FDA might have. So are you interested in just medical products themselves? Are you interested in outcomes? Are you interested in outcomes after exposure to a particular medical product? And answering that question will help identify both which level of analysis you're doing and which type of tool is applicable. So first, we have the tool options when you are interested in investigating a medical product only. You can identify how the drug's utilized, and within that subcategory, identify the appropriate tool for your investigation. So are you interested in utilization only? Or what about overlap or switching between more than one product? Are you interested in characterizing utilization within a pregnant cohort? And we have one option for outcomes only to describe background rates, and then several more for medical products and outcomes, which allow you to calculate incidence rates and also control for confounding using propensity scores. Each of these analyses is considered a type of analysis, so type 1 through type 6, as you can see listed out here. What I'll do in the next few slides is walk through some of the tool capabilities on a really high level, so you get a sense of what's possible within the Sentinel system. And really, like, again, it's a crash course. It's not intended to make you an expert in any of these types of tools, but to give you enough background to understand what you can do within the Sentinel system and then where to go to get more information about particular tools or analyses. So this first example, what I'll be doing is giving a really big picture overview of each of these different analyses that are possible with an example, a real life example to illustrate the capabilities. It's the highest level of information to give you a broad understanding. So the first tool I'll introduce today is medical product utilization, our type 5 tool. You'll use this tool if you want to understand how frequently a medical product is dispensed and characteristics about its utilization. And the tool will output the number of patients and episodes in a particular period of time. So you'll get information on the average number of dispensings, the average day supply, length of episode, and gaps between episodes. There's an enormous amount of output with this tool. It's a very powerful tool. And an example I'll walk through today is using the type 5 tool is sinus stents for nasal polyps. And were you to search for sinus stents and nasal polyps on the Sentinel website, you might come up with this query right away. So this is a screenshot that you'll get for all of our analyses. And this is the sinus implant one that I'm going to walk through. So you'll see there's this landing page that lists the details and additional information about the analysis, including the medical product of interest, and then the description of the analyses, and then at the bottom, the deliverables. And here, and in most cases, the deliverable is the actual report from the Sentinel analyses that were conducted using our tools and the output that was generated from that. So within the report, you'll see that the results are aggregated across all the data partners that ran the analysis. Within the report, there's also an overview section that functions kind of like an abstract and methods, where it gives details about the analysis questions and parameters that were selected, the query period, which data partners ran the analysis. And so you can just click that deliverable section at the bottom of that page and get the PDF of that report. So our example here is this type 5 query looking at mometasone furoate and sinus implants used in nasal polyps. And this is a descriptive analysis. And it was looking at dispensing patterns of mometasone furoate by examining cumulative exposure episode durations, first exposure episode durations, and so on. And additionally, the output was reported based on whether or not the patient had a recorded indication for glaucoma or cataracts prior to receiving the stent. So I'm just giving you a screenshot of just one of the many tables from this report. There's just too much to share beyond this little screenshot, but this is an example. You'll see the table describes exposure duration of different mometasone furoate stents overall, and by cataract and glaucoma status. And the report template includes total patients and then statistics about the exposure length. Again, it's just one of many tables you'll get. So I encourage you to go click the link at the bottom of your screen to learn more. All right. So our next analysis, I'll review the type 1. This is our descriptive analysis tool that allows us to get background rate information of a particular exposure, outcome, or condition. So if you're interested in understanding how many people have hypertension, if you want to calculate the rate of hypertension, this is the tool you would use. The report generates counts of members with the exposure or outcome or condition of interest, as well as characterizes the observable person time and the rate. So a recent query I'll walk through looked at hypertension in the pediatric patients, where FDA explored different ways of identifying pediatric patients with hypertension. And this is what you'll see on the website, where we have the description and the deliverables. In this type 1 analysis, we estimated rates of hypertension among members less than 18 years old. And then you can see there was 2 different definitions. It was really an exploratory analysis, right? So one definition was more restrictive, looking at patients with 2 outpatient claims within 183 days and 1 inpatient claim. And the second definition was broader and only required 1 hypertension claim. And in the table here, we have number of members, diagnoses, the eligible members and member years, and then calculated risk of hypertension per 10,000 eligible members. As with the other examples, I'm just moving through these very quickly. There's so much more detail that you can look at and get from the actual reports on the website. Moving on, the next analysis uses our Type 4 tool, which assesses medical product utilization during pregnancy. This tool can identify patients with evidence of a live birth delivery and then use gestational age codes to estimate pregnancy start and trimesters. So it uses the insurance claims data to establish the pregnancy period. And once that timeline is set, the tool can assess medical product use during specific trimesters or during the entire pregnancy, or even in the period before the pregnancy. The tool can also identify a cohort of comparator patients, so in terms of age, enrollment, and calendar time. And these comparator patients do not have evidence of a pregnancy at that same time period. So you are able to compare a pregnant cohort to a non-pregnant cohort to understand drug utilization during pregnancy in the same broad group of patients. And the report will give you a number of pregnancy episodes and medication use within each pregnancy period for all of your cohorts of interest. And the example I'll walk through now is when FDA needed to understand and describe multiple sclerosis drug dispensings among pregnant patients with live birth deliveries. And this really was an analysis where Sentinel could shine because these are not common drugs. They're even less common in the pregnant population, but we do have a large enough database to support a descriptive analysis. And this is how you'll see it on the Sentinel website. For this particular analysis, you'll see the deliverable and the Sentinel report that you can actually download and review. And in this example table, you'll see we describe counts of medical product dispensings by drug of interest, as well as year of dispensings from 2017 to 2020. So each row is a different product with counts and proportions of pregnancies with evidence of use at any point during pregnancy. And moving on, we'll look at both medical products and outcomes using the Type 2 tool. In this most simple version of the tool, we can estimate unadjusted incidence rates of an outcome after an exposure of interest. So there are many metrics that are output and many different tables that are generated by the Type 2 tool, but broadly, the output will include counts of exposure episodes, patients, and outcomes, as well as person time. And in this example, I'll be showing results from another mometasone analysis, this one looking at incidence of ocular events after exposure to sinus implants. And again, here is what you will see on the website. It does look a little bit different here. You'll see this analysis resulted in 3 reports looking at different outcomes and different definitions of the exposure. So FDA had a lot of questions around the use of sinus implants and different outcomes related to visual acuity. So in this example from one of the reports, the specific events of interest were glaucoma and cataracts after 1 and 2 years of follow-up. And these outcomes were examined among patients with evidence of different stents, some single use, some repeated use. So each row in this table is a different product of interest. We'll see patients who have evidence of use of that product, and then we can see how many eligible members there were. This is the denominator. And then the rate of exposure, years at risk, average years at risk, and then the number of events overall and number of users within an event. In the last column, we have our rates for each of these exposures, and you'll see we do have some small cell counts and some rows have been redacted. So this is a descriptive analysis, and these are unadjusted rates. But we are able to do some adjustment. We can control for confounding also using a type 2 tool. The type 2 tool offers propensity score adjustment and covariance stratification. So we're moving on now from the descriptive analyses to the inferential analyses in the context of the type 2 tool. I'll be focusing my example on the propensity score adjustment, but just note that there's really this range of capabilities within the different propensity score analyses. So we can do propensity score matching, as well as inverse probability of treatment weighting, which you'll learn much more about in the next few presentations. So there's a lot here. I'm only giving you a very big picture overview, but the point is you can estimate propensity scores within your exposed and comparator cohorts, assess outcomes of interest, and then use the propensity scores to control for confounding. You'll get descriptive statistics comparing the baseline characteristics between cohorts, and then inferential results with hazard ratios and confidence intervals. And on the Sentinel website, we have an example looking at cutaneous small vessel vasculitis following dispensing of dabigatran, rivaroxaban, and apixaban. So this was a propensity score matched analysis. It did follow a lot of preliminary descriptive work. You'll see here that there are 2 deliverables posted, and this is both the analytic package to run the tool and then the report with the output. So in this analysis, we identified new users of rivaroxaban, dabigatran, apixaban, and warfarin with a documented diagnosis of atrial fibrillation, and then evaluated the outcome of cutaneous small vessel vasculitis. And of course, controlled for confounding using one-to-one propensity score matching. So in this table, we do see the results from the Cox proportional hazards models comparing rivaroxaban users to warfarin users, counts of users, the person, time, and events, incidence rates and risks, and then the hazard ratios and p-values for each comparison. So there's a lot here. You'll see that this table is separated out into 3 sets of results. So the site adjusted analysis, which is the results before matching, and then the conditional analysis and the unconditional analysis, which are the results after matching, but differ in the ways they handle person, time for our risk sets. So that was a super quick overview of the propensity score matching within Sentinel. But again, you'll learn more about IPTW shortly. And our last example, I'll review, it's another type 2 analysis using the interrupted time series functionality. And this will identify population level outcomes at different time intervals and will quantify change in outcomes after a specific point in time or an intervention, which could be a safety warning or an FDA label change of some kind. And the report includes figures to display the predicted trends and tables showing inferential analysis results of level and trend change estimates, as well as absolute and relative differences at certain time points after the intervention. So the example I'll show is looking at longitudinal trends and incident and prevalent use of long-acting beta agonists. And what we have on the website here, there's really just, like, as you can see from all these bulleted lists, there's such a wealth of output for this particular analysis with 4 incident reports. There's 4 prevalent reports, and then along with the query package, there are 9 deliverables, which you can't see here because it's so long in the screenshot, but it's definitely on the website. And this request estimated the longitudinal trend in incident and prevalent use of long-acting beta-2 agonists with and without long-term asthma control or medication among asthma patients in the Sentinel distributed database before and after a 2010 FDA drug safety communication that had cautioned against using LABAs without an asthma controller medication. So FDA wanted to have an understanding of the impact of that drug safety communication and if it impacted the rates of LABA use in the Sentinel distributed database. What I'm showing here It's just from report 1, looking at longitudinal incident rates and incident use with the dispensing of single ingredient LABAs. And this is one of many, many figures you'll get output in the report, and it shows the proportion of incident LABA users without same-day asthma controller medications before and after the drug safety communication in 2010. And again, there's so much output here. I do encourage you to check out some more of the reports on the website. All right, so in my concluding section, I want to make sure you know where you can find all this information because it is all available to you. We have a public Git where these tools are located. The Git includes the tools themselves, so the SAS code, as well as packages for the analyses, which would be the SAS code, the parameters selected for the analyses, and then the documentation defining the parameters used within the tools. So this is for everyone. It's not just for FDA, but everyone who's interested in using the tools or just understanding more about them. When you go to dev.sentinelsystem.org, you will see a list of the public repositories we've made available. And these include the Sentinel Common Data Model documentation, as well as the routine querying tool documentation. What I have here is what you would see for the quality assurance package, which is I talked about earlier in this presentation. So we give a brief description of the package and then the folder structure and requirements. And you can use this whether you want to learn more about how we QA check the Sentinel data, or if you transformed your data into the Common Data Model, you could run the same checks that we do. And you'll be able to download the actual SAS program and then run it against your own data. If you wanted to download one of the analytic tools that I mentioned today, so let's say a type 2 tool to assess exposure and outcomes, you could click here and that will give you the tool in its template form where you could then specify the parameters or review the documentation. And we also have the analytic packages themselves. So for all of the inferential analyses that are conducted as part of Sentinel, we post, in the interest of transparency, those SAS programs. You already saw them listed as part of the deliverables in the previous examples I walked through. And within the analytic packages, you'll be able to see the exact parameters that were specified. So the code list to all the input files, etc. If you wanted to learn more about the IPTW analysis that Dr. John Connolly is presenting later, you could come to this website, select the request ID, so this first one here, for the inverse probability of treatment weighting analysis from the drop-down menu, and then check it out. And this is the screenshot where that request ID will take you. And within this site, there's a lot more information than I have presented on the screen here. You'll be able to download each of the source folders for the input files, the documentation, and then the SAS programs that were used to run the analysis. And with that, this concludes the introduction to Sentinel and how the network is constructed and the broad overview of analytic capabilities. At this time, I believe we have some time for some questions. All right, so I see we do have a question. Will the recording be posted on the Sentinel site? So yes, it will. And we will also be emailing the slide or sending a link to where the slides are for all attendees. All right, well, thank you, everyone. At this time, I'd like to hand things over to Dr. Zhao Yuan Li, who's going to be talking about inverse probability weighting.
Thanks, Jen. That was a really great summary. Hi, everyone. I'm going to talk about inverse probability weighting. Inverse probability weighting has been increasingly used for effect estimation in observational research. My plan for the next 30 minutes or so is to give you a high-level introduction to inverse probability weighting, and in particular, inverse probability of treatment weighting. I hope this introduction will lay a foundation for understanding the next presentation on this amazing inverse probability treatment weighting tool in the Sentinel Routine Querying System. I also hope by the end of this introduction that you'll begin to appreciate the main idea behind this approach for confounding control, which is rather straightforward for causal analysis using observational data, and also to recognize the potential applications of this approach. For today, we're trying to answer 4 main questions. Basically one what question and 3 how questions. The first, what is inverse probability weighting and how does it work? How do we implement it in a study, and how does this perform compared to other confounding adjustment approaches? Oops. Okay, as Jen just had a really nice review of the Sentinel initiative, which was launched in 2008. This is a national post-marketing safety surveillance system for regulated medical products. An important tool for safety monitoring is observational studies using large health care databases. Observational studies, when well designed and carried out carefully, they can complement findings from randomized controlled trials by providing evidence, including the long-term effectiveness and safety of the medical products when used in routine clinical practice. However, as observational studies do not have the benefit of randomization to allocate by chance the risk factors for an outcome of interest. So the exposure groups may have different baseline risks for the outcome, making it more of an apples to oranges comparison instead of an apples to apples comparison, and leading to the so-called confounding bias. Confounding is the concept of comparability or the lack thereof in observational studies, which hampers causal inference. It arises when a factor is associated with both the primary exposure of interest and also the disease outcome of interest, resulting in this distortion of the association between the exposure and outcome. In this diagram here, we're interested in measuring the impact or the strength of association between statin treatment and mortality. And because older people are more likely to take statin, and they are also at greater risk of mortality. A direct comparison of mortality rate in the statin users and non-users group will be biased due to the confounding by the age variable and not reflect the true treatment effect. So how do we address confounding? And sorry, I lost control. Okay, how do we address confounding and try to transform this apples to oranges comparison back to the apples to apples comparison? Fortunately, there are multiple ways to do this. In the design stage, we can remove confounding by using randomization, restriction, or matching, although we talked about randomization is not possible in the observational studies. In the analysis phase, methods such as standardization, stratification, or multivariable regression adjustment can be used to adjust for confounding. As illustrated by this simple diagram, or directly a cyclic diagram here of a DAC, this method function by putting a box around this age variable, so blocking this path from statins through age to death, and allow for more direct estimation of the effect of statins on mortality. But no matter which method we choose to use, it is essential that we adequately measure all relevant factors in a study. Inverse probability weighting is another approach that can be used for confounding control. Through weighting, as suggested by its name, it creates a pseudo population in which the association between treatment and measured confounders is removed, which is equivalent to this removing this arrow between age and statins, making the two exposure groups more comparable. The origin of inverse probability weighting can date back to 1952 when it was developed for civic sampling. Here we would like to do inference from one sample to the population, but if there is a differential selection among individuals with different characteristics such as gender, the ordinal sample quantities such as means or proportions are likely to be biased estimates of their corresponding population quantities. Weighting can be used to weight these individuals to create a sample with no differential selection, so more like the population. As in survey sampling, the weighting makes the sample surveyed look like the population the sample was drawn from. Weighting in the inverse probability weighting or inverse probability treatment weighting reweights each exposure or treatment group to look like the entire study population or study sample so that they share the same covariate distributions. I know some of you might be thinking, oh, this does sound familiar. If you are thinking that you are not alone, and exactly this is just like standardization, which is a common method used for confounding control, as we learned in EPI 101. And inverse probability weighting is just a way of standardization. So what do I mean by that? And I also want to show you how, in another way, why we say that. So here's a simple visualization here. So we have an observed study population of size n, and with treated individuals shown in orange on the left, and untreated individuals shown in green on the right. The same colors are also used to show the distribution of covariates, say the age variable in the two exposure groups. We can see that the two distribution of age in the exposure groups different from each other, and also from the age distribution in the overall study population showing as shown in blue in the middle. So with weighting, when we apply this inverse probability of treatment weighting, we'll end up with a weighted sample or a pseudo population comprised of two groups, one group all treated and one group all untreated, both with the same size of n and sharing the same covariate distribution as the entire observed population. So now through weighting, we have transformed the apples to oranges comparison into an apples to apples comparison, and we can then estimate the treatment effect of interest had the entire population been treated versus had the entire population been untreated, which is the average treatment effect in the population, or known as ATE. But how does weighting achieve this? Basically, how does the inverse probability weighting work exactly? Let's try to work through a simplified example together. Later on, Dr. Connie will walk you through with more real use case, but here we're trying to use a really toy example to try to illustrate how that works. Thinking back to our previous example of statin treatment, so basically studying the effect of using statins versus not using statins on mortality. Instead of age, let's say, let's consider another confounder having type 2 diabetes. So in this study, we have a total of 14 individuals in the study. 6 of them have type 2 diabetes, shown as the orange color on the left, and 6 people without diabetes, showing in the blue color on the right. The prevalence of having diabetes in the entire population would be then 6 on the left divided by the entire sample size, which is 14. So 6 over 14, which is 43%. And within the treated group of 6 individuals, there are 4 people who were treated. And so the proportion of having diabetes among the treated group is it's 4 divided by 6. So there are a total of 6 treated patients, and which gives us the number of 67%. And then within the untreated group, so this just kind of the circles without the color fillings that we want calculated diabetes within the untreated group, then we found out will be 2 over 2 plus 6, 8, 2 over 8, which is 25%. So because the 67% versus 25%, then we see there is an imbalance in the distribution of type 2 diabetes between the 2 exposure groups in the study sample. And we know that having type 2 diabetes will also affect the risk of mortality. And so that in this study sample, we know the observed effect of statin treatment on mortality is confounded by this variable type 2 diabetes, and adjustment is needed. So to make the treatment group just like the overall study population, which has a total of 6 diabetics and 8 non-diabetics, and in the treatment group we have only 4 diabetics and 2 non-diabetics. So just to make this treated group more like the overall study population, we need to weight each of the 4 treated diabetics individuals by 6 over 4, which is 1.5. And if you look at this, it's actually 1 over the probability of being treated among diabetics. And each treated non-diabetic individuals will be weighted by 8 divided by 2, which is 4. It again is also the 1 over the probability of treated among non-diabetics. So as you can see, for everyone in the study, their weight is just the inverse of the probability of having the observed treatment value conditioning on their confounding value. So we have done this for the treated group, and then we'll do the same for the untreated group. And while the untreated diabetic individual will each receive a weight of 6 divided by 2, which is 3, while the untreated non-diabetic individuals each receive a weight of 1.33, which is the 8 over 2. And so now with this inverse probability of treatment weighting, and also later on we're talking about this will be the unstabilized inverse probability treatment weighting, we created a pseudo population of a size 28. So twice of the original sample of 14 that we started with, and now 14 people with everyone treated, and 14 individuals are untreated. And the distribution of diabetics in the treated group is now 6 divided by 6 plus 8, which is 6 over 14. And the distribution of diabetics in the untreated group is also 6 divided by 14. So the previous imbalance in the diabetics in the treated and untreated group, which was 61% versus 25%, is gone. And now they have the same distribution of diabetics as the proportion of diabetics in the overall study population, which is 6 over 14, the 43%. This is exactly the reason why we were saying a couple slides ago that inverse probability weighting methods reweights each exposure group to look like the entire study sample so that they share the same covariate distribution. Now with this weighted sample or the pseudo population, we can then go ahead to do our effect estimation. What you can do is to just set up a 2x2 table and count how many individuals in the treated group had an outcome event and how many in the untreated group had an outcome event, and then get the risk to calculate the effect measure of interest, such as risk ratio or risk differences. As you can see, the implementation of inverse probability of treatment weighting, inverse probability of weighting, weighted estimation is quite simple. We can then summarize this in a 3-step process. First, we will model the exposure or treatment A as a function of confounders or covariates L, and then we'll then assign each individual a weight. So everyone in the sample will receive a weight, which is the inverse of the predicted probability of having the observed treatment value given the covariate value L. We'll then obtain the measure of effect measures of interest in the weighted sample or the pseudo population because the weights are estimated and unknown. And also we're using weights which induces this within subject correlation. We need to use the robust variance estimator or bootstrap-based methods for variance estimation to account for this uncertainty in the weights. Now let's take some time to discuss each of these 3 steps in more detail. In the first step, we model exposure as a function of covariates that we suspect to be confounders, and different types of exposures can be accommodated using different models. Say if we have a binary exposure, which is quite common in drug safety studies or other effectiveness studies, that we can use a logistic regression model to estimate this treatment. And if we have another type of exposure, such as a categorical variable or continuous variables, there are also other models that are available and can be used for estimation of this predicted probability. After getting the predicted probability of the exposure for each of the individual in the study sample, now we'll assign each one a weight that is 1 over the predicted probability of receiving the observed treatment they received. So for a binary exposure, that is basically 1 over the predicted probability of being treated for the treated individual, and 1 over the probability of being untreated, which is also the same as 1 over the 1 minus the probability of being treated for the untreated people. Now, let's take some time to just look at the formula for a little bit. You may recognize that the denominator of this inverse probability of treatment weights look just like the propensity score. Propensity score, as many of you know, is a confounding summary score that is commonly used in pharmacoepi studies. The propensity score is a conditional probability of being treated given the covariates. And patients with similar propensity scores have similar distribution of the confounders used to estimate the propensity score in expectation. So now using the propensity score, then for the treated group, their inverse probability of treatment weights is basically just 1 over propensity score. Well, for the untreated group, the weight is 1 over 1 minus propensity score, because again, the inverse probability of treatment weights, it is the inverse of probability of receiving the observed treatment given covariates. So as we have seen, there is a close connection between inverse probability weighting and propensity score, especially when we use the weighting approach for confounding adjustment after estimating the propensity scores. A common issue with the inverse probability weighting is that the treated individuals may have really low propensity score, while untreated individuals may have really high propensity score, which will end up with really extreme weights and potentially make the weighted estimator highly unstable, and result in estimators with really large variance. So reducing the statistical precision and also have this wide constant intervals. One way to help in this situation is through the use of stabilized weights. The stabilized weights are calculated by multiplying the regular inverse probability weights we just went over with the marginal probability of observed treatment weights without conditioning on the confounders. So the numerator of these stabilized weights now is this marginal probability of observed treatment instead of 1 in the unstabilized weights. These stabilized weights preserve the original sample size, while the unstabilized weights doubles the sample size. This property can actually make it a really good diagnostic tool for checking the distribution of the weights. If you were expecting to have well-behaved weights, the distribution of the weights should have a mean of 2 or close to for unstabilized inverse probability treatment weights, and a mean of 1 for stabilized inverse probability treatment weights. In the setting of extreme weights, we also should also reassess the propensity score model or the treatment model and try to identify positivity or near positivity violation. And then we will want to train the non-overlapping propensity score regions. We can also truncate weights by resetting weights larger than the specified threshold to the value of the threshold in order to reduce the influence of individuals with really large weights. Inverse probability weighting is a quite flexible approach. I have been talking generically about inverse probability of treatment or inverse probability of exposure weighting under a sufficient set of causal assumptions. This approach estimates an average treatment effects or ATE in the entire population, which is basically the contrast of everyone in the study sample being exposed versus everyone unexposed. Using the standardization language, the standard population here, or the target population, is the entire observed study population or study sample. We can also alter the weights to get other treatment effects, such as the effect of treatment among rows or treated using standardized mortality ratio weighting, or known as SMR weighting. When we use SMR weighting and also the observed treated population as the target or the standard population, this approach measures the contrast of everyone who actually received treatment under treatment versus the treated group had they not receiving treatment. And we can also alter this weight, SMR weighting, to get the average treatment effect in the untreated when we use the standard population, when we use the observed untreated population as the standard population. This visualization shows how SMR weighting compared to the regular inverse probability of treatment weighting. So here on the left is the inverse probability treatment weighting. We just saw that we found after weighting, the slope population will have twice the sample size as the original population. And now with SMR weighting, if we use the treated individuals as a target, then after weighting, so each the treated individuals in the study will all receive a treatment of 1. So the sample size will stay as the same. As you can see, the size of the orange part stays the same. And for the untreated group, they're going to receive a weight which is the purposes of odds. And then you can see that the untreated individuals, the green part, now after weighting in the pseudo population, they will have the same size of the treatment group in the original observed population. And if we use the untreated individuals as the target with SMR weighting, as you would have imagined or expected, that after weighting, the size will be similar to the untreated individuals before weighting. And the distribution of the covariates also differs. So with inverse probability of treatment weighting, the distribution of the covariates in each of the exposure or the pseudo population will be similar to the distribution in the population. which is the standard. But when the target is the treatment group or treated group in SMR weighting, the covariate distribution in both treatment groups after weighting using this weights will be similar to the covariate distribution in the treated. The yellow curve here, and if we switch the target population to the untreated, this distribution, covariate distributions will be similar to the covariate distribution in the untreated group, the green curve here. So in step 3, after we've done weighting, we can now do effect estimation by getting the summary statistics in the weighted data. And we talked about that we can use just a simple 2x2 table. Alternatively, we can also fit a model, but without covariates, because we have already controlled confounding through the weighting, so we are not putting any covariates into the model, and thus this will estimate a marginal effect. So how does inverse probability weighting compare to the other confounding adjustment approaches, such as the covariate-based methods that we mentioned at the beginning of this section? These methods, they estimate different effects, as we've shown that inverse probability treatment weighting estimates marginal treatment effect, covariate-based or covariate-adjusted regression, covariate matching stratification methods, they actually estimate the conditional treatment effects. So depending on your target treatment effects of interest, you may want to choose one approach versus another. If you are interested in conditional effect, this covariate adjusted methods that work well when the number of confounders is small, which however is usually not the case in drug safety studies, where we normally have rare outcomes and also have a lot of confounders that we need to adjust for. So with that, propensity score-based methods, including the inverse probability treatment weighting approach, will be able to accommodate this by try to reduce this high dimension to a single dimension. And another benefits of using inverse probability of treatment weighting over the other covariate-based methods is that sometimes we know better or we know more about the treatment assignment or treatment selection process than we know about the disease process. So that will be able to more likely to correctly modify modeling the probability of treatment, which is easier than correctly modeling the probability of disease. There are also some differences between all this propensity score-based adjustment methods between weighting, inverse probability weighting versus propensity score matching and stratification. Well, inverse probability weighting and propensity score matching, one-to-one propensity score matching, they offer comparable strong confounding control. The methods could estimate different causal effects. Well, inverse probability treatment weighting or one-to-one or one-to-n unconditional propensity score matching, they estimate marginal treatment effects. One-to-one conditional propensity score matching or one-to-n variable ratio propensity score matching, and also propensity score stratification, they actually estimate this conditional treatment effects. And in comparison to other propensity score-based methods, this weighting-based adjustment method is more flexible and can estimate treatment effects or different causal effects of interest. we can alter the weights as we have seen earlier to estimate the average treatment effect or ATE in the entire population, or just average treatment effect among the treated or among the untreated. And we can also estimate the treatment effect that are more policy relevant contrast, say the effect of treating everyone versus the standard care. We can also bring in data from external population that is more of interest when this more of interest than the current study population, and then get the treatment effects in the target population. And here are a few disclaimers before we conclude on this introduction. Inverse probability weighting or inverse probability of treatment weighting is not magical cure-all. It cannot solve all unmeasured confounding and can only achieve balance on the measured factors. And inverse probability weighting is also sensitive to positivity violations and will generate substantially large or small weights when their covariate patterns potentially violate positivity, leading to this wider constant intervals or imprecision. Today, we just focused on the basics of inverse probability weighting or the inverse probability, in particular inverse probability treatment weighting. If you are interested in learning more about the technical details and also the use of inverse probability weighting in other settings, such as estimating the effects of time varying treatment, using inverse probability of censoring weighting, or for dynamic treatment strategies, there are a lot of great resources out there, and I included some of them here for your reference. I hope by now I was able to convince you that inverse probability weighting is just a way of our familiar, our friend standardization and the common method for confounding control. And it is quite a flexible approach for confounding control in observational studies. But please note that weighting cannot solve unmeasured confounding, and it doesn't free us from needing the causal assumptions to interpret all these results causally. And with that, I would like to conclude the section and see if you have questions.
Hi, Jacqueline. I've been, this is John Conley. I'll turn on my video. I've been sort of monitoring the chat, and there are a bunch of really great questions. I thought we could maybe take this time to discuss them, if that's okay with you.
Sure.
Okay, we can start with the first one. I think was a good question about, I think related to your figure with the pie charts. When we're doing SMR weighting or any type of stabilized weight, you know, what would you expect the proportion of treatment to look like within the pseudo population in terms of how it relates to what you saw in the original population?
Is this, do you mind repeating the question? Sorry,
Sure. Yeah, so I don't mean to make it like a test for you or something, but I was thinking when I saw this question from Philip about whether when you do like a SMR weighting or something like that, the question was more about, would you expect to see a prevalence of exposure after weighting that matches the original population, or would you expect to see them to be equal in size? And I was thinking we would see that it matches the original population's treatment prevalence when you do that type of weighting.
Yeah, I think so. Sorry,
Okay.
I did not catch that.
Yeah, no, sorry, I didn't ask that very well, but I think that captures kind of the spirit of the first question. I think the second question was about, related to the rarity of the outcome and how many covariates we want to adjust for when we're doing IPTW. And the question sort of asking if there is a problem with using lots of covariates when you have a very rare outcome when you're using when you're using IPTW. I was curious if you could just speak to that.
Yeah, it's actually why we would like to use the inverse probability of treatment weighting, or even any of the propensity score-based methods, is that we don't need to worry about putting the how many covariates we can put in the outcome model, like the other outcome-based or regression-based methods. Here we have already included all the confounders in the treatment model that we're not need to worry about having number of covariates in the outcome model, which basically we talked about is has no covariates. So I'm also looking at the question and was asking whether that would the rarity affect the weights. I think the rarity of the outcome it doesn't affect the weights because the weights is actually related to the treatment, so it's about actually related to the treatment prevalence in your study.
Great. So I think the next question was a good one that I confess I believe the answer is that yes, people have looked at it, but I don't know of any particular studies off the top of my head. So it's asking about the fact that weights are estimated and therefore come with some error, which we're typically ignoring. Has anyone examined the impact of this error? So are you aware of any studies that have looked at that?
Yeah, that's a great question. This actually has been already looked at extensively because the weights or if thinking about the treatment weights or the propensity score, they are not known. So we have to estimate using a model, then there's this variability in that, and we need to account for that. And also at the same time, by using the weights that so some subjects will be weighted by, say, just like in our example, a size of 4, and they'll introduce this within subject correlation because they have the same outcome. With all of this, we have to account for all this variabilities, and the regular standard error would just be biased, and there have also been comparison between the robust standard error or the so-called sandwich estimator, and also the bootstrap based methods, and it has been shown that sometimes the robust standard errors will also be biased, and then the bootstrapped method will be preferred. I can also I can also share some references on this kind of comparisons after this, if there's a forum for that.
Okay, great. So I think the next question was about, when you're comparing IPTW to other methods, sometimes I guess it's been shown in the PROTECT consortium, and I've also seen this as well in my own work. Sometimes IPTW will give you the same, effect estimate basically as using some of the other propensity score methods like matching or stratification. And so I guess the question here is more about what the advantage is of IPTW over some of the other potential propensity score methods and why you might choose it.
I think, first of all, I have to say that I don't know a lot about the PROTECT consortium. I apologize for that. But if I understand the question correctly, it looks like it's more about the time varying in the time varying covariate adjustment setting, and we're talking about whether inverse probability of treatment weighting, how does that compare to other purposes or methods? First of all, I don't think the purposes for matching would be a good method when you have this complex treatment confounding feedback loop, because some of the confounders would be both time varying confounders and also mediators by including the covariates in the model that would actually result in bias because they will reduce this artificial association. So in both settings, the inverse probability treatment weighting or even other more complex methods like G methods, G computation, or G formula will be more recommended. And inverse probability weighting has also another benefits that I did not get into the details is it also have a more well-defined target population when you compare to say the other purposes for based methods, say matching or stratification. When you do matching and you by removing the individuals that are unmatched, we actually started to lose become a little difficult to articulate with what kind of purpose, what kind of target population is. And by comparing inverse probability treatment weighting margin structure models compared to other the G methods, inverse probability treatment weighting is less prone to model misspecification compared to the other methods, the parametric G formula or the structural nested estimation. But because we only need to worry about the treatment model, while the parametric G formula and others for time varying confounding control, they actually need to have model specification for all the other covariates, time varying covariates and confounders, so you are more prone to model specification. I hope I answered the question. If I actually went off track, let me know and I can follow back up on this one.
I think then since we have, I think, a few more minutes that we can discuss, I might just jump to the last one because I think it may involve a little more discussion, and just to sort of read it to you at a high level. You have any examples where there might be too much, I guess, essentially differences between the groups you're comparing? For example, if you want to compare drug A for stage 1 versus drug B of stage 2, I guess presumably for cancer, largely, serious of diseases is different between your comparison groups, and there's presumably a lot of confounding. We can do IPTW, but should we? And if you're in that situation, what precautionary steps would you recommend?
Yeah, that's a great question. I think first is always about if you actually are expecting a lot of heterogeneity, we need to first think about whether it is comfortable to do this overall estimation or not. If you want to do a more stratified analysis first, and then can do the inverse probability treatment weighting within the different groups. Because I think if we have, say, I think the example has drug A for stage 1 versus drug B for stage 2. The first question is how comparable are the two exposure groups? If you already don't think this two groups are not that comparable, we need to think of other ways to make sure the groups are can be compared first. And then if, say, I'm also taking another way is if instead of in this example, when you have different stages of disease comparing that versus if you have the same stage disease, but different subgroups may have treatment effect heterogeneity, and you would like to consider that, you think you need to think about what are the subgroups you have, and then you can choose. I would recommend doing stratification first, and then do the analysis within the subgroups. I don't know, John, if you have anything to add to that.
Nope, I think that's what I would say as well. And then I think there was one other question, which I guess moved over my screen, but is a last but not least question certainly would be where you could go to learn more about IPTW, some of the assumptions, if you had a reference slide already, or what you would recommend to someone who wants to learn more about it.
Yeah, and also feel free to reach out if you are looking for more resources. I'm happy to share as well.
Thank you, Dr. Lee. That was a great introduction. And thank you, everyone, for these wonderful questions. It was a really great discussion, very, very detailed. If you could advance to the next slide, I just want to give us all a break. So let's take this time for a 20-minute break. So that will get us back at 11:05 Eastern. Thank you all. We'll see you in a few. Welcome back, everyone. We'll continue with the final section for today's training. And at this time, I'd like to introduce Dr. John Connolly, who will be walking through an analysis using inverse probability of treatment weighting in Sentinel.
All right, hello everyone. Thanks, Jen, for the introduction. My name is John Connolly. I'm one of the Sentinel research scientists, and I'm excited to talk to you today about IPTW, kind of in general, and then specifically as we've operationalized it within the Sentinel tools. So in terms of the agenda for my part of the presentation, I'd like to start off with a quick review of how IPTW works kind of at the conceptual level through the lens of a hypothetical case example. Then we'll move to talking about how IPTW has been operationalized within the Sentinel tools. Then we'll actually show you an example of where we applied IPTW within Sentinel for the very first time. And then we'll end on some conclusions. So as you've heard in Dr. Lee's presentation, the goal of IPTW is really to remove the association between your measured confounders and your exposure of interest. And then by breaking that association, of course, remove that measured confounding. This goal isn't unique to IPTW. Essentially, all propensity score methods kind of have this as their goal, but the most commonly used ones like matching and stratification achieve this goal by putting patients into these mutually exclusive groups based on their propensity score. Well, of course, in contrast, IPTW achieves this goal by assigning patients a weight based on their propensity score. So as I mentioned, we're going to start off by going through kind of a case example together of how IPTW works conceptually. And we're going to discuss it through the lens of a previously published paper that you see cited on the slide here that compared users of oral anticoagulant drugs on their comparative risk of stroke, bleeding, and mortality. So, for the interest of time, we're just going to keep it simple and only look at one of the comparisons of interest from that prior paper that you see cited there, and that is comparing rivaroxaban versus dabigatran. And we'll only look at one of the outcomes from that paper, which was stroke. So you can imagine if you want to do this hypothetical study that we could collect data on sample size of 20 patients. And so we can start building our data set. As you see right on the slide here, each of the patients in our population will have a unique identifier. And of course, in this case, we decided that that's their name. So our goal here is to estimate a causal risk ratio comparing rivaroxaban versus dabigatran on an outcome of stroke. And so of course, we're going to need to measure that exposure and that outcome for every patient in our data set. So you can see we've added those columns to the data set here. Exposure is color-coded, blue for rivaroxaban, gold for dabigatran, and stroke is operationalized as a yes/no variable. And then because this is, because of course this is IPTW and we're doing an observational study, we want to adjust for some confounders. And in this case, we'll keep it simple and just look at one binary confounder, and that is cardiovascular disease, or CVD. So as you can see, we need to measure this for every subject in the population as well. And so we tack that on to the end of our data set. So now we have everything we need to move forward and essentially do IPTW together in this case example. So stepping back for a second, as we said before, our goal is to estimate a causal risk ratio comparing rivaroxaban versus dabigatran on the risk of stroke. Now, if we're willing to make certain assumptions, specifically if we're willing to assume that we have fully adjusted for confounding by controlling for cardiovascular disease status, we can actually use the observed associational risk ratio that we actually see in our data to estimate the desired causal risk ratio that kind of involves a hypothetical or counterfactual contrast that we can't observe directly. So taking this figure from the cited causal inference book that you see here, I think it's a really nice illustration of the difference between these two types of associations. So on the lower right, you have the associational risk ratio that we can observe directly from the data set that we just built together. That would be the observed risk in patients who actually got rivaroxaban divided by the observed risk in patients who actually got dabigatran. On the lower left, you see what the causal risk ratio is that we're trying to estimate. And that is comparing the risk if everyone in the population had been given rivaroxaban, which of course only some of them were in real life, versus the risk in a hypothetical or counterfactual world where everyone had been given dabigatran instead. And so you can see kind of that's involving a full population contrast. So again, we can't observe that causal contrast directly, but if we're willing to make this assumption about fully adjusting for confounding, then we can actually equate these two things. So in this really simple situation where we have a binary exposure, a binary outcome, and a binary confounder, and only 20 patients, we can actually visualize IPTW directly on the slides here. So that's what we're going to do. So on the left, we have the data set that we built previously. And on the right, we have little avatars for each of the 20 patients in our study, color-coded by their exposure. So the first thing that we'll do to perform IPTW is to essentially stratify or split the population into mutually exclusive cardiovascular disease groups. There's the patients without cardiovascular disease on the left, and there's the patients with cardiovascular disease on the right. We can calculate the probability of the confounder here. So the probability of not having cardiovascular disease is 8 out of the 20 subjects. The probability of having cardiovascular disease is 12 out of 20, or 60% of the patients in our study. The next thing we need to do in order to perform IPTW is to start calculating conditional probabilities. In this case, specifically the conditional probability of exposure within each cardiovascular disease group. So starting with the CVD equals no patients on the left, we can look at the data set. There are the 8 patients at the top of the data set, and we can clearly see that half of them were given dabigatran, 4 out of 8, the other 4 out of 8, or 50% were given rivaroxaban. So we'll write those probabilities down right on the slide, and we'll come back to them later. And then we'll do the same thing for the CVD equals yes patients as well. We can either look at the data set or look at the avatars and see pretty clearly that 3 out of 12 of these patients were given dabigatran, 9 out of 12 were given rivaroxaban, so a 25-75 split. So again, we'll record those probabilities, and then we'll move on to the final thing that we need, which is to calculate the probability of our outcome, stroke, within each of these mutually exclusive exposure and cardiovascular disease groups. So again, starting with the CVD equals no patients on the left. Again, they're at the top of the data set. If you take a look over at the stroke column, you'll notice that 1 out of 4 dabigatran patients who don't have cardiovascular disease experience a stroke. So that conditional probability is 25%, so we'll write that down. And it's the same for the rivaroxaban patients as well. 1 out of 4 of them experience stroke. So then to sort of fill this out, we'll move to the bottom of the data set where our cardiovascular disease yes patients are. And we'll do the same thing. We can see that 2 out of the 3 dabigatran patients experience stroke, and 6 out of 9 rivaroxaban patients experience stroke. So 2/3 probability in each group. So now that we've gone through that, we have all of the conditional probabilities we need to move forward with IPTW. So before we do that, though, I want to take a step back and remind us about what it is we're trying to do here, and that's estimate the desired causal risk ratio, specifically the risk in a hypothetical or counterfactual world where everyone in our population got rivaroxaban, divided by the risk had everyone in the population instead been given dabigatran. So we can sort of take this on in pieces. So we'll start with the numerator. So like I said before, if we're willing to make this very critical assumption that cardiovascular disease status is the only confounder that we need to adjust for, and we've perfectly measured it, we can actually use the observed risk in the people who were actually exposed to rivaroxaban in real life to estimate what would have happened in this counterfactual or hypothetical situation where we actually gave the entire population rivaroxaban instead. So because we're willing to add an assumption, we're able to equate an association with the causal effect estimate. So here's a quick refresher on what our actual study population looked like. On the left is the data set again, and on the right, the avatars. I would just take a quick second to look at what happened to the rivaroxaban patients, because that's who we're going to be focusing on in the next slides. So when we ask our counterfactual or hypothetical question, what if we gave everyone in the population rivaroxaban? We can actually adjust the data set to reflect that reality. So obviously the exposure group would be rivaroxaban for everyone. So you can see we've updated other colors. We've updated all the other conditional probabilities here. And the CVD column would also stay the same because this is what we want to adjust for. So it's important we measure it accurately. We're not interested in manipulating that information. It's really critical that that stays the same. So the only column that we really don't know when we ask this counterfactual question is, what is the probability of stroke? Specifically, we have those 2 probabilities we calculated before, the probability of stroke conditional on rivaroxaban and not having cardiovascular disease, and the same one for having cardiovascular disease. So what would those be? Well, we don't have to guess out of nowhere. We actually have a pretty good idea because we're willing to make that assumption again. And we observed that 25% of the rivaroxaban patients in real life who didn't have cardiovascular disease had a stroke. If you'll remember, it was 1 out of 4. So we would expect then to see the same proportion of patients experience a stroke in this hypothetical reality we've created here. So 25% of the larger number of 8 would be 2. So we would expect 2 out of 8 patients to experience stroke based on what we observed in this hypothetical scenario. So we can start filling out the data set here as well. It doesn't really matter which 2 patients experience the stroke, so we'll just give it to the first 2. And now we can just do the same thing for the patients who do have cardiovascular disease. Again, we don't have to make up a number. We can use what we observed in real life, and we saw that 6 out of 9, or 66%, or 2/3 of these patients who really got rivaroxaban in real life and actually had cardiovascular disease experienced a stroke. So in this hypothetical or counterfactual scenario we've created for ourselves, we would expect to see the same proportion of patients experience a stroke. So 2/3 of the 12 patients you see listed here would be 8. So we would expect 8 out of 12 of these patients to experience stroke. So now you can see we've completely filled out the data set for this particular scenario. And by calculating the probability of stroke conditional on cardiovascular disease, as we've just done, we've effectively adjusted for it. So we can put the population back together again and answer our question. The risk of stroke, if we gave everyone rivaroxaban, would be 10 out of 20, or 50%. So going back to the causal risk ratio, that's our numerator. So now all we need is, of course, the denominator to get our final answer. So we'll just go through the same process again for dabigatran, but obviously sped up a little this time since we are probably familiar with it. But the principle is the same. We're under the assumption that we've adjusted fully for cardiovascular disease. That's the only thing we need to adjust for. We can use what we observe to estimate what would have happened in a hypothetical causal counterfactual scenario, as it's often called. So here's the observed study population again. You can take a quick second to refresh your memory about what happened to the dabigatran patients here. So if we ask the question, what if we give everyone dabigatran? Again, the only thing we don't know is the conditional probability of stroke. The other columns are sort of self-explanatory. So we'll again use what we observed in real life to answer this question. So we saw that in the CVD equals no population, that 1 out of 4 dabigatran patients had a stroke. So we would expect to see the same thing happen here. 25% of 8 patients is also 2. And we'll do the same thing for the CVD equals yes patients as well. 2 out of 3 of those patients who actually got dabigatran in real life and had cardiovascular disease experienced a stroke. So we'd expect to see 2/3 of the patients with cardiovascular disease in this situation experience a stroke, which is of course 8 out of 12 again. So now that we've adjusted for cardiovascular disease, we can put the patient population back together again and answer the question from our denominator, which is the risk of stroke if everyone got dabigatran is 10 out of 20, or 50%. So going back to the causal risk ratio, now we can calculate our causal risk ratio. Of course, it's a causal risk ratio of 1 in this example. And for reference, had we not performed IPTW and done this adjustment, we would have observed an unadjusted risk ratio of 1.26. So we've gotten rid of some upward confounding by cardiovascular disease status. So we don't have to actually, of course, when you're doing IPTW in real life, you don't have to go through it sequentially like this. You can consider both of these counterfactual scenarios at the same time. So I've shown them here on the slide, and you can see pretty clearly that there are 40 patients here as opposed to the 20 patients in our actual study. So this is what we call the pseudo population. And again, it's in this example twice as large as the original. And the reason for that is, of course, that we've essentially copied each patient twice. There's a different version of them within 2 different hypothetical treatment contrasts that we wanted to make here. And so the reason that we can use this pseudo population to estimate our causal risk ratio is because within this population, there is no confounding because cardiovascular disease status is completely unassociated with exposure here. And to prove it, we can just break the populations down into cardiovascular disease status. And of course, the probability of having cardiovascular disease is the same for both rivaroxaban and dabigatran patients. So there is no association between this variable and exposure anymore after we've done IPTW. And so we've achieved the goal that we set out at the beginning to break that association between our measured confounder and the exposure of interest within the pseudo population. So, you may be thinking you've just gone through this, kind of painstakingly detailed example of IPTW, but we haven't explicitly talked about IPT weights at all. And the reason is because we were actually implicitly calculating them when we were going through that previous example. So, in our observed population, for example, there were 4 patients who don't have cardiovascular disease that were treated with rivaroxaban. Those are those 4 patients in blue, kind of right in the middle of the slide. When we ask that counterfactual question, what if we gave everyone rivaroxaban? Now all of a sudden there's 8 patients who don't have cardiovascular disease that are treated with rivaroxaban. And so, we've implicitly weighted each of these observed 4 patients by a weight of 2. And it turns out that there's obviously a shorter, more efficient way to do IPTW that you can get straight to the pseudo population without doing kind of the illustrative process we've just gone through. And that is to recognize that asking our counterfactual question is equivalent to weighting each patient by 1 over the probability of their observed exposure, conditional on the confounders you want to adjust for. So for us, that's just cardiovascular disease. And so that's exactly the probabilities that we calculated within the red box down here. So for those rivaroxaban patients, we get a weight of 2 because 1 over their conditional probability there is 0.5. So 1 over 0.5 is 2. And you could go through and do that for all of the other mutually exclusive combinations of cardiovascular disease and exposure and get an IPT weight for everyone in the population. So as we've just shown, and as Dr. Lee talked about, to calculate an IPT weight, really all you need is the probability of your observed exposure or a patient's observed exposure, conditional on the confounders you want to adjust for. So for really simple situations like the one we just went through, you can obviously do this by hand, but of course in real studies where things are more complicated, you might have continuous confounders. You're of course going to need to use regression models. So for exposed patients, the probability of the observed exposure given their confounders is the exact definition of a propensity score. And for reference patients, it's not exactly the propensity score, but you can easily get the quantity you need by taking the complement of their propensity score. So that's been the quick review of how IPTW works at a conceptual level. Now I'd like to move into talking about how IPTW is operationalized within the Sentinel analytic framework and the Sentinel tools. So the first thing that the Sentinel tools will do when you use them to perform IPTW is to calculate a propensity score that you've specified at each data partner. And then after that is done, the tool was built to enforce a mandatory trimming of non-overlapping regions of the propensity score distributions. There's a couple reasons for doing this. One reason is to help potentially avoid assigning patients very large weights, which as we'll talk about later can be potentially problematic for IPTW analyses. Another reason is that this is often just generally recommended to help improve the internal validity of your estimates by excluding patients who don't have any suitable comparators in the other treatment group. So after you've decided what propensity score you want to estimate, the tool will go ahead, it will estimate that each data partner, it's going to do the mandatory trimming. The next choice you sort of have to make as you're putting together your analysis is what exact type of IPT weight you'd like to use. So here are the options that you have. There's a couple choices here. You can either choose to use weights that will allow you to estimate an average treatment effect or an average treatment effect in the treated. And then if you choose the average treatment effect weights, you have the choice of whether or not to stabilize them. So we'll talk about these weights in a bit more detail in turn. So let's start with the ATE weights. So these are weights that are going to use the full population, the exposed and the reference combined as your reference standard. So what that means is after you do the weighting in that pseudo population, you would expect the patient characteristics to reflect the distribution of those characteristics in the full combined population. So of course, then what that lets you contrast is if the full study population had been exposed versus if the full study population had been instead given your reference drug. So this probably will sound familiar to you because it's what we used in our case example. So here are the equations for the ATE weights. You can either stabilize them or not. Our example, when we were doing it before, used unstabilized weights. So we simply just did 1 over the propensity score or 1 over 1 minus the propensity score for exposed and reference patients. In the Sentinel tools, you do have the option to stabilize these weights as well. As Dr. Lee talked about, in theory, these do have different properties. The stabilized weights may be more efficient in certain situations. However, within the Sentinel context and what the tools are currently built for, which is non-time varying exposures and binary exposures, we'd expect to see similar point estimates and 95% confidence intervals regardless of which one you choose. So moving on to the ATT weights, these are weights that use the treated population only as your reference standard. And so what that means is after you do ATT style weighting, the patient characteristics in the treated population are going to reflect the distribution of those characteristics in the treated patient specifically. So of course, what that means is that an ATT allows you to contrast if the treated population had been exposed which of course they were, versus had the treated population instead been given the reference exposure. And so I think it's helpful to think about the ATT as essentially an ATE within a subgroup, and that subgroup is the treated patient specifically. So here's the equations for the ATT weights. For the exposed group, their weight is just a constant of 1, and for the reference group, their weight is the propensity score odds. So when it comes to choosing which one you want, if you're not sure, I think it's helpful to remember that we would expect these two different effects to be the same in a randomized trial. And the reason for that is because we wouldn't expect to see any systematic differences, either measured or unmeasured, between treated and untreated or reference patients because of the randomization. But obviously in observational studies, we do expect to see this a lot of the time. And so when that happens, these two effects can differ, specifically if there is a systematic difference in a characteristic that actually modifies or changes the true causal treatment effect. So which one you prefer, I think really just depends on what your research question is and who you want to generalize your results to. Are you interested in making causal statements about people who look like the treated population to the extent that they are distinct, or are you interested in making causal statements about the full treatment population? So, after you've chosen the type of weight you want, the tool is going to estimate a hazard ratio and a robust 95% confidence interval, according to a procedure that's been outlined by Xu et al. In the paper that you see cited here. I wanted to take a second to talk about this because it's very exciting, because this was a recent manuscript that, for the first time outlined how to perform IPTW with risk set or summary level data, which is the type of data that we most frequently work with in the Sentinel system. So a quick word about what risk set data is. To maximally protect patient privacy and to make sure we can use the largest possible sample sizes from all of our data partners, the DPs typically do not share a 1 row per patient, what we call individual level data set, back with the Sentinel Operations Center. Instead, what they share is a summary level information, or summary level data set that contains information about the risk sets that were formed at each site. And so because this type of data return is a bit different than what traditional regression or statistical techniques will accommodate, it does require that you develop appropriate techniques. And so that's what the authors of this paper did. And so that is what allowed us to finally add IPTW to the Sentinel analytic framework. So some considerations when you're using the Sentinel tools to do IPTW. One thing to note is that we built them such that when you do a subgroup analysis, this requires that you re-estimate a new propensity score within your subgroup. So some of you may be familiar with the fact that when you do matching or propensity score stratification, there are lots of good papers out there showing that you don't necessarily need to re-estimate within the subgroup, under certain conditions. But for IPTW, it's been shown, as cited here, that it is a bit more sensitive to propensity score misspecification within the subgroup. Just borrowing the overall propensity score may not be suitable when you do IPTW especially. And kind of the high level intuition for that is because, as we just talked about, IPTW is using that propensity score value, the actual probability, directly to calculate the weights, and that's where the adjustment comes from. Matching and stratification, the value is also important, but ultimately the goal there is to match someone up with someone with a similar propensity score. So the absolute value is a little bit less important. And so that's why we built the tools to reflect this difference. So you do need to re-estimate your propensity score when you do subgroup analyses in IPTW. So, moving on then to our applied example, where we actually use the tools to do an IPTW adjusted analysis for the first time. We chose to replicate a previously published manuscript. This is the same one that inspired our case example earlier, as well as a previously completed Sentinel analysis that used propensity score matching, because at the time we didn't have IPTW to try and replicate the original paper. So once we got it, we wanted to try it out in this situation where we have done some prior work. And specifically, we wanted to use it to compare direct oral anticoagulant, or DOAC, users who are age 65 and up within Medicare. So for this workshop, we're only going to focus on one of the DOAC comparisons from these prior analyses, and that's, again, we'll stick with rivaroxaban and dabigatran. We'll also focus on just one of the 4 outcomes that we looked at in the real study, and that is thromboembolic stroke. So here's the design diagram for our applied example. You can see that the study period ranges from October 19th, 2010 through September 30th, 2015. And patients entered the cohort on their first eligible dispensing of either rivaroxaban or dabigatran, and we call that day 0. Prior to the day 0 or index date, we required patients to be continuously enrolled in both medical and drug coverage for at least 183 days, but we did allow gaps of up to 45 days in that enrollment. In terms of the inclusion and exclusion criteria, we did apply some again over the prior 183 days. Specifically, we were most interested in patients who were being treated with these drugs for atrial fibrillation only. So that was our inclusion criterion. And we excluded patients who had indications, other indications for anticoagulant therapy, like joint replacement, transplants, et cetera, valve repair replacement. So we also excluded, of course, patients who are taking, for the purposes of this comparison, other anticoagulant drugs or warfarin. And then we also excluded patients who had an institutional stay encounter on their index date. In terms of the exposure washout, while I just mentioned that we wanted to make sure patients weren't using other DOACs, we did also want to make sure that this was a new dispensing for either rivaroxaban or dabigatran. So we did enforce a 183-day exposure washout, excluding any patients who had previously been given dabigatran or rivaroxaban before their index date. We did not exclude any patients who had previously experienced the outcome of interest, and we didn't apply a blackout period. In terms of the follow-up, it started on the index date and continued based off of the day supply of the subsequent dispensings. So we bridged together dispensings that had a gap in the day supply of 3 days or less, and we added a 3-day extension period onto the final day supply of the final dispensing. And patients were followed until they had the outcome or they were censored. And they could be censored for stopping their initial treatment, being dispensed a different DOAC drug, dying, having their data end for any reason, or having a variety of the other censoring criteria you see listed here, or of course, the query end date occurring. And then last but certainly not least is our covariates, which we're going to use to do IPTW. Those were also measured over the prior 183 days and included things like demographics, age, sex, race, as well as various cardiovascular risk metrics like HAS-BLOOD score, CHA2DS2-VASc score, and then various other prescription drugs and diagnoses, as well as health services utilization. So we used all those covariates to, of course, estimate a propensity score model, which we'll then use to perform IPTW. And we were interested in performing a subgroup analysis in this particular query. So we did that, and we specifically were interested in the male-female sex subgroup. And of course, then we re-estimated our propensity score models as well within each subgroup as well as overall, because as we've talked about before, that's the way we built the tools to work. So of course, we're going to use IPTW to do our confounding adjustment, and we chose to use the stabilized version of the ATE weights for this example. Now, there is one other decision that you can make when you're using the Sentinel tools to do IPTW that we haven't talked about before, and that is whether or not you want to truncate the IPT weights. And so a little bit about weight truncation. I know you already heard some about this from Dr. Lee, but when you have a patient whose propensity score conflicts with their exposure group, so a treated patient who had a very low predicted probability of treatment or a reference patient who had a very high predicted probability of treatment, these patients are going to end up with very large weights, and therefore they'll be very influential in your IPTW analysis. So, just stepping back conceptually, when you see these types of patients, especially if there's a lot of them, this may raise questions about how well your propensity score model has been specified. If there is something about these patients that the physician making the treatment decision is seeing that your model isn't, especially if that variable is a confounder, you might want to reassess your model. But most of the time, I think we do our best with the data that we have to adjust for these things. And sometimes unusual patients just occur, not necessarily because of unmeasured confounding. And so, patients with very large IPTW weights may be present in your population. And when they are, this can reduce the statistical precision of your final effect estimate. So we try to avoid this by design a little bit in the Sentinel tools by, again, doing that mandatory trimming we talked about before. This excludes some potentially unusual patients from the tails of the distribution. But in the event you still have patients with very large weights in the data set, we do have some ways of dealing with them. And that is, again, that we have the option to perform a weight truncation. So the Sentinel tools require pre-specification, just like they do for all other parameters when you're doing an analysis of your weight truncation thresholds. You're allowed to pick multiple of them because you make these decisions in the absence of seeing any data. So that's what we did here. So we decided to pick 3 potential weight truncation thresholds, either doing no truncation, taking 1% off of either side, or taking 2.5% off of either side of the weight distribution. So the way weight truncation works is it doesn't exclude anyone from the population. It just resets their weight down to the value or up to the value of the threshold that you chose. So it's operationalized symmetrically within the tool. So if you do 1%, you have to take 1% off of either side. So as a visualization of this, let's say you had this very nice normal distributed distribution of weights. If you said, I want to truncate at the first and 99th percentile, and you see that the 99th percentile weight equals 10, any patients in your population who have an IPT weight that is larger than 10 would just have their weight reset to equal 10 instead. So, the way that I think it's most helpful to think about this decision is to sort of operate in the world where you assume your propensity score model is correct. You probably wouldn't be doing the study if you didn't think that necessarily. But in that case, your weight truncation decision represents a classic bias variance trade-off that we see all the time in epidemiology. If you have a correct propensity score and you go in and you change the weight, which is effectively the same as changing your propensity score, now your propensity score model that was correct is by definition no longer correct. And so you're not going to get the full confounding adjustment out of that propensity score model anymore. But this may be worth it to you because if it's just a little bit of bias, but a large reduction in the variance, then this may be a decision you'd want to make. I think it's interesting that conceptually, if your propensity score model is incorrect, that weight truncation can actually reduce both your bias and your variance. But I don't think this is particularly, and this is outlined in the paper I've cited here, I don't think this is a particularly practical result for us, especially in Sentinel, because the optimal amount of truncation that you need to do in this situation is going to depend on the specifics of your particular study. And we'll never know if we exactly, hit the right amount of truncation on the nose. So I think ultimately the bias variance trade-off framework is the best way to think about weight truncation. And so, like I said, we recommend testing out or taking multiple potential truncation levels, and then having this sort of pre-specified rule established beforehand that we'll use the effect estimate that corresponds to the weight truncation threshold where the weights were most quote unquote well-behaved. So what does that mean? As Dr. Lee outlined before, it means that the observed mean weight is close to what you would expect. And so that's kind of the first pass thing that I would recommend when you're choosing between the thresholds. If you kind of see a tie based off of that metric, you can then move to looking at the one with a smaller standard deviation, because that would theoretically give you a more precise effect estimate. So for unstabilized ATE weights, as we've shown in our case example, the expected mean weight is 2. When you stabilize those weights, the expected mean weight is 1. And for ATT weights, the expected mean weight would be 2 times the prevalence of your exposure. If you see deviations from the expected mean weight, and when you look at the weight distributions, which the Sentinel tools output and we'll look at on the next slide, this can imply that you have either a misspecified propensity score model or some combinations of covariates where patients either always or never receive the exposure. So this is a violation of the positivity assumption. So, given all of the context that we've just discussed, the way that we approach this in Sentinel queries with a mind to reducing, even the appearance of choosing a weight truncation threshold that would, correspond to the effect estimate that we like the best or anything like that, we review these weight distributions. The tools allow you to review the weight distributions, and we also, of course, discuss them with FDA before we ever go on to calculate the effect estimate. So we make this decision in a results blind way. So here are the weight distribution tables that the Sentinel tools produce. So in our case, there's only one data partner. So there's just one row for that data partner, and then there's the aggregated row underneath it, which is of course the same in this example. So you'll see different tables for each of the 3 thresholds that we considered. And then each of them will produce information about the minimum, the maximum, the mean, and then the standard deviation. And so just looking at the mean column first, you can see that when we don't do any truncation, we're right kind of on the nose of where we would expect for these stabilized ATE weights with a mean weight of 1, at least to the 3rd decimal place. As we do more and more truncation, as you move down the side, you can see that the mean weight is starting to move ever so slightly further away from the target. But at the same time, the standard deviation is also getting smaller and smaller. So I think this is a a nice example of kind of the bias variance trade-off in action. We ultimately decided not to do any weight truncation here because not only was the mean right on, but if you look at the maximum weight, it's not very big. It's only 3.6. So we didn't really feel that there was a problem with extreme weights here that we needed to address with weight truncation. So again, before we ever calculate any effect estimates, we decided not to do it. And so all of the results I'll show you in the future slides are going to come from this scenario where we don't do any weight truncation. So before I do show you some of those results, I wanted to take a quick second to talk to you about one of our newest parts of our Sentinel analytic framework, and that is Sentinel Views. So a lot of the slides that I'll show you upcoming came from the Sentinel Views platform. And so Views is a web-based data visualization application that gives you interactive and customizable dashboards that we can use to display the results from our Sentinel queries, in not only nice looking ways, but also ways that hopefully will give us more insight into, our results. And so this will be a publicly available resource that you'll be able to log into. I'm going to provide the links shortly within the slides. And so I wanted to show you, what it looks like when you log into Sentinel Views. And so this is the analysis that we did, that we've been talking about within Sentinel Views. This is kind of the main landing page when you navigate to that particular scenario. So you'll see a lot of kind of metadata at the top, reminding you of what you're looking at. So here's our exposure of interest to rivaroxaban, our reference group to Bigatran, and of course our outcome. The study period is up there. Other information about inverse probability of treatment weighting, et cetera. And then across the middle, where you see the highlighted summary tab, that's the current dashboard that we're looking at. This gives you, this tab gives you a preview of some of the other dashboards to come. So you can see a preview of the covariate balance dashboard, as well as the propensity score distribution dashboard. But there are, of course, several others like an incidence rate, forest plot, et cetera. And so I wanted to, on the next slide, have a short video that sort of takes you through me kind of going through each of these, or a selected sample of these tabs to show you kind of just a taste of what Views can do. Unfortunately, I don't have a full presentation, which Views would deserve to talk more about the things that it can do. But again, just to give you a preview, this is me navigating through the summary tab here. You can see a preview of the forest plot as well. The first dashboard that I wanted to take a second to look at was the covariate balance dashboard, which produces these very nice pre-generated love plots with both the standardized mean difference as well as the absolute difference for all of the covariates in our study. So we had about 50 or 60 or so variables in this study, so quite a few of them. And these charts are highly customizable. So for example, you can restrict the variables. I've just restricted to only variables that are used in the propensity score estimation. And of course, you can full screen this. You can also, restrict even further if you'd like. You can change the colors, et cetera. And then another really cool thing that you can do with the Sentinel Views platform is to download these plots as image files directly to your computer. So you just saw how I did that here. And then, of course, you could add that directly to a paper, send to a collaborator, et cetera. Another dashboard I wanted to show you is the propensity score distributions. We'll look at these in more detail in the coming slides, but just wanted to give you a quick preview here. Again, highly customizable. These correspond to the plots you get from the Sentinel tools. There's a results table tab, which has some hard numbers about the number of patients, events, and the hazard ratios, of course. There's pre-generated bar charts for your incidence rates. Again, highly customizable and downloadable as images. And then my personal favorite is the forest plot that's automatically generated at the end. So here showing pre and post adjustment. So like I said before, Views is a publicly available resource, and a subset of the approved queries by FDA will be made available for the public to view within the Views platform. And the goals for this public use are to, number one, increase awareness of the Sentinel system as a resource for public health, and number two, to increase access to Sentinel systems tools through an interactive resource. So Views can be publicly accessed at views.sentinelsystem.org. And again, you'll be able to go in and see the dashboards that I was just showing you that correspond to this particular query, not only for this particular analysis, but all of the other comparisons and outcomes we looked at. So returning back to the actual results now, here is a custom love plot that I made in Sentinel Views. You can see I've really restricted the number of variables that I'm showing you here, not only because there was too many to fit on the slide, but also because I just wanted to highlight, kind of how good our pre-adjustment covariate balance was in this example. Rivaroxaban and Bigatran are, of course, very similar drugs in the grand scheme of things, used for similar indications. And so there really wasn't a lot of imbalances in our measured covariates before we did any adjustments. So that's what the blue dots are showing you. Again, this is the standardized mean differences. We have vertical lines at our sort of a priori decided thresholds of the standardized mean difference of 0.1. And you can see that, even for some basic demographic characteristics, those are all well within our thresholds to start with before we do any adjustment. The only two covariates out of, again, the 50 or 60 or so that we adjusted for that were, imbalanced based off of our threshold are nicotine dependency and digoxin use. As you can see, they just barely were over the lines. But after we do IPTW adjustment, as signified by the gold dots in the middle, everything was very well balanced. So we were, not thinking there was a lot of measured confounding in this example, just right off the bat. So here's more larger screenshots of the propensity score distributions that I got from views. Again, I didn't do any customization to this really, but you could change the colors, you could change the titles, etc. if you wanted to. You won't be surprised to see that the largest color there is the yellow for overlap, because as we just talked about, there's not a lot of covariate differences before adjustment in this population. So not surprised to see the propensity score distribution overlap is also quite significant. Of course, after we do IPTW adjustment, again, it's another plot you can get from views and it comes out of the tools. The overlap is now nearly complete. So IPTW doing a good job at adjusting for the measured confounding that we have here. So here's a table of the effect estimates. This does not come from views, although there is a corresponding tab available in views. I wanted to take a quick second to show you this tab because it has a little more information about some hard numbers from our analysis. So the way that these tables are structured is you see the different columns giving you various metrics of number of new users, number of events, of course, hazard ratios, etc. And then horizontally, they're split out into three sections when we do weighted analyses in the Sentinel tools. The first section will give you just that site-adjusted pre-IPTW weighted, unweighted patient counts, event counts, and crude hazard ratio, etc. The middle section will give you those same metrics, but after you do propensity score trimming, but before weighting. The reason we wanted to add this section was in the event that the mandatory trimming does get rid of a lot of patients and a lot of outcomes. We wanted users to still be able to know how many patients, how many outcomes actually contributed to our final adjusted hazard ratio. And then the bottom of this tab is where you'll see the IPTW weighted metrics for all of these different columns. So focusing on a couple numbers specifically, there were 110,000 rivaroxaban initiators in our study, around 85,000 dabigatran users. We had a decent amount of outcomes. We had about 550 total. And our crude, our unadjusted, unweighted hazard ratio was 0.87. Typically, it says site adjusted here. Typically, we have multiple sites in our studies. In this case, we just have one site. So this is really corresponding to a crude estimate. In the middle of the section, you see that after we do propensity score trimming, again, no surprise, we really don't lose anyone out of the almost 200,000 patients. The mandatory propensity score trimming excluded about 3 people in this example, again, just because of the great overlap we have in this particular comparison. And then at the bottom, of course, of most interest after we do our IPT weighting is the IPT adjusted hazard ratio, which you can see here was 0.9 with a confidence interval from 0.76 to 1.06. So again, no surprise that it's fairly similar to the crude hazard ratio, given what we measured and adjusted for. So if you'll recall, we did do a subgroup analysis by sex. So I was really excited to be able to use views to make these forest plots, which I think are a great addition to the Sentinel analytic capabilities. You can see at the top the overall effect estimate of 0.9, and then split out by female and then male sex respectively. So it appears that the male users had a slightly more protective association here than the female users, although the confidence intervals are fairly wide and do overlap greatly. So, that's kind of it for the applied example. I wanted to just take a second to kind of do a high-level discussion of where IPTW fits within the propensity score methods that we have available in Sentinel. I put together this table of some of the strengths and limitations of the competing methods we have, like propensity score matching and stratification. Mostly, just focusing on the IPTW here. The reason that, at least I know I'm personally excited about being able to use IPTW is that, it offers that strong confounding control that you can get from matching, but it doesn't cost you the sample size loss that you might find when you do one-to-one propensity score matching. In terms of the limitations or considerations you have to use relative to the other methods we have available, within the tools are that you do need to re-estimate your propensity score within subgroups like we talked about. You don't need to do that for matching, although you have the option to. And so that may, make your analysis a little bit, just larger in terms of the number of scenarios or output that you have. But again, I think is the right thing to do scientifically. And then IPTW does also have this additional step of at least considering what to do with your weight truncation and potentially large weights that, of course, non-weighted methods don't need to deal with. So, sort of in conclusion, and to wrap things up, the addition of IPTW to the Sentinel tools has, really met FDA's need for increased analytic flexibility. We don't just have to do match analyses all the time anymore. We like it because it offers that strong confounding control without the sample size loss that's inherent to at least the one-to-one form of propensity score matching. I'm kind of proud of the fact that at the Sentinel Operations Center, we, and by we I mean the authors of that paper, developed a method to perform IPTW using the risk set level data that we most commonly use within the Sentinel system. So that's what allowed us to finally add it to our toolbox, as I mentioned. And this is again proven to produce, as you can see outlined in that paper, proven to produce the same effect estimate that you'd get from a more traditional one row per patient level analysis. But again, using the type of data that we use most often in Sentinel. So in terms of how the tools actually work for when you might be using them yourself, it's kind of split into two parts. So the first part, the distributed part, is known as Query Request Package, or QRP. This is the part that's sent out to the data partners, who have their data in the Sentinel Common Data Model format. And this is what produces the analytic data sets, that risk set level data that we need to do IPTW. And then there's a second component, which is run locally at SOC when we do it as part of a Sentinel query, is the local reporting tool, or QRPL. This takes that analytic data set that QRP makes and then allows us to generate all the output, including tables and final effect estimates. So this kind of natural split between the distributed QRP and the local QRPL kind of fit in nicely with the weight truncation decision, just to return to that for a second, because we're able to use the analytic data sets from QRP to make that decision about weight truncation. And then once we've decided it, then we run QRPL, and that's where we get our effect estimates. So again, this is how we can make decisions in results-blind ways. So again, both of these tools can be run on any data set that's stored in the Sentinel Common Data Model format. And if you are interested in downloading the actual analytic packages that were used to do the applied example we just talked about, as well as another link to the views dashboard, you can find them all at the URL that's going to be included in the slides here. We'll take you to this page, and you can see at the bottom the deliverables are, first of all, the Sentinel analytic package, actual SAS code, et cetera. The second deliverable there is the standard QRPL modular program report. And then the third deliverable there at the bottom is a link to the Sentinel views dashboard. So I think to totally wrap it up now on the final slide, Sentinel's newly implemented IPTW capability, we're pleased to see was successfully applied for the first time in a query that compared the risk of stroke and bleeding outcomes among DOAC users. And it was a nice example to try it out in, because we did have some previous work, not only the published paper, but also the previous propensity score match query that we could use to kind of calibrate our estimates, and we found almost exactly the same things. So I think that's just about it for me. These are the references, or at least some of them, that I used to put together this presentation. I would really highly recommend checking them out if you're interested in learning more, especially to that earlier question. I think the causal inference book that's cited here is a really great and freely available resource that you can use to learn more about IPTW in general. And then we do also have some research references here, like the SHU paper, to learn more about how it works in a distributed database like Sentinel specifically. So thank you so much for your attention, and I'd be happy to take any questions that haven't already been addressed.
Thank you so much, Dr. Connolly. So I just wanted to reiterate, we got a couple questions that we were able to answer while you were presenting. But there was a good one about views. So there was a question about whether we look at individual estimates at each data partner, or if we assume a common effect. And there was a question about that. So we were able to answer it, and I'll just bring it up here, is that we don't do meta-analyses. And Dr. Connolly answered that during the presentation, but we return summary data that can allow us to calculate point estimates and robust confidence intervals according to that SHU 2020 paper that you brought up. And then if you go to Sentinel views, you can actually look at the site-specific estimates as a forest plot. And I'll also say, if anyone has any questions about any portion of our 3 presentations, now's the time to bring that up. We do have one more here asking for the link to the Sentinel views, and that is views.sentinelsystem.org, and we've also typed it here in the Q&A. All right. So again, thank you, Dr. Connolly. That was really interesting. And thank you everyone for joining us today. At this time, I'd like to take a few more minutes of your time for our post-training survey. I mean, you know it now, we love our data. So I'm posting this now. And we'd really value your feedback here and to let us know what you thought of today's public training, and all of your feedback will help us continue to create quality trainings in the future. So thank you for your input. Well, thank you everyone for your responses, and thank you so much for your attending today. So these slides will be posted on the Sentinel website later today, and you'll be getting an email with the location, and you'll also be able to have access to the recording. Before we're done on the next slide, I just want to acknowledge all of the people who put so much work into today's presentation, not just for the presentations, but also everything for the tools to the analyses. It just is, there was a lot of people involved. So thank you, everyone. And with that, we will conclude for today, and I appreciate all your time. Thank you.